Hi there, I'm Lucy Macdonald, physiotherapist. Welcome back to my virtual clinic. Today, I'm super excited to introduce you to a special guest, Mr. Nick Ferran, who is a consultant shoulder and elbow surgeon, and we're going to be talking about frozen shoulder. So, Nick, is there anything else that you would like to add before we get stuck into the frozen shoulder?
Firstly, Lucy, I'd say thanks for having me. It's good to collaborate and learn from each other and discuss topics like frozen shoulder that are common but still challenging. I'm a consultant shoulder and elbow surgeon in London, sort of northwest and central London, and I do both NHS and private practice. If patients want to get in touch and ask questions, they can get in touch via my website, which is www.shoulderandelbowlondon.com. And I also have a YouTube channel with other videos and patient information and advice.
Really helpful, thank you. So let's crack on. I mean, probably the best way to start is just to ask the question, what is a frozen shoulder?
Sure. Frozen shoulder is a common condition in the UK that affects patients usually in that term that we all hate, middle age, from about 40 to 65. It's more common in women than in men, and diabetics get a more aggressive form of the disease, but most of my patients who have frozen shoulder are not diabetic. We don't fully understand the cause, but in most cases, frozen shoulder wouldn't have an obvious cause or injury. But some shoulder conditions, pre-existing shoulder conditions, can trigger it. And it's thought that it's an inflammatory process that happens within the joint, and that's why it's got another name, which is adhesive capsulitis. And we think that there is inflammation in the joint lining. That inflammation causes pain. That pain causes muscle spasm, which restricts a bit of movement. And then as the disease progresses, that joint lining becomes thickened and scarred, and that causes the sort of global stiffness that can happen later on. So in a nutshell, that's what it is, an inflammatory disease that eventually leads to thickening and scarring of the joint capsule that starts off as a painful condition and then becomes a condition that's predominated by stiffness.
Interesting. And I guess if people are watching this, perhaps they've got shoulder pain themselves. How do they know if it's a frozen shoulder that's causing their pain or perhaps something else?
Well, as I say, early on it's a little bit difficult because the first sort of symptoms are usually pain without a history of injury, and it's something that will gradually come on. And I think patients initially might ignore the symptoms at first, and then as they progressively become more intrusive, they become aware of it. Early on, the pain can be very nondescript. Usually in the shoulder region, patients point to their sort of deltoid region, can sometimes go down to the arm. And in frozen shoulder, the pain is usually more common at night, and patients find it uncomfortable to lay on the affected side. But it's only when the stiffness starts that patients start to become aware, and it makes it easier for us as clinicians to pick this out as a frozen shoulder. When the stiffness isn't yet present, it's very difficult to tell it from other conditions that can cause shoulder pain. And some of the common stiffness that patients notice, especially early on, would be things like difficulty putting their arm into a jacket, reaching a seatbelt from behind, and then eventually reaching up to high objects, etc. But it's usually reaching out to the side, external rotation movements that first start to be affected, and then as the condition gets worse, they can struggle with all movements.
Absolutely. And if someone is watching this and suspects they're kind of listening to what you're saying and they're thinking, oh gosh, that sounds like me, what are the treatment options available? And I guess within the similar sort of categories, what's likely to be the outcome of the condition? Because obviously they're probably thinking, oh gosh, that all sounds terribly scary, although that physiological process. But but what are the treatment options, and what's the outcome likely to be?
Sure. Okay, well, I guess it's probably helpful first to try and talk about natural history, how the disease normally progresses if you do nothing.
Mm.
And full condition, it then progresses to having issues with pain and stiffness.
Mm.
Then the pain settles and the stiff phase can stay for quite a long time.
Mm.
And we used to tell patients that if you leave frozen shoulder alone for it would get better on its own in about 2 years. But we now know from some Scandinavian studies that up to 7 years, patients still have symptoms in their shoulder.
Mm.
And the treatment options you might use depend on how they present. So if they present early on in the disease where there isn't much stiffness, but it's predominantly pain, then things like anti-inflammatory drugs, physiotherapy to try and help address some of the triggers and some of the adaptations in movement that develop and prevent stiffness can be quite useful.
Yeah.
And if you can nip the condition early in the bud, they may not get to that stiffness phase. As a surgeon, most of the patients that come to me are already stiff, and then the options for management vary. So first line of treatment in my hands would be a steroid injection into the shoulder joint. And that's something that can be done straight away in clinic once we confirm the diagnosis. And I would expect that patients would get back to normal activity in about 50% of cases. Other options for management include hydrodilatation. That's a more complex injection. It's usually done under ultrasound guidance and uses high volume of fluid, but also steroid. So it is like a large steroid injection, and the current evidence base shows that hydrodilatation and injection patients end up being the same at about a year. If you fail these interventions, physiotherapy, steroid injections, anti-inflammatories, and the shoulder is predominantly stiff, then you have two options really: wait it out and see if it'll improve on its own, or if that stiffness is actually limiting work, recreation, etc., then the next step is some form of surgical intervention. And with surgery, we have two options. The less favored option is something called manipulation under anesthetic, where we put patients to sleep and we crank on their arm, and it tears that thickened, scarred capsule and frees up movement. But that's quite a brutal process. It's a short operation, but quite brutal, and it's uncontrolled. And so a more finessed approach is an arthroscopic capsular release, which is a keyhole operation where we look inside the joint and we use instruments to take away the scar tissue from inside the joint. And that frees up the movement in the joint. Both manipulation under anesthetic and arthroscopic capsular release, which is my preference, require about 3 months of physiotherapy afterwards to maintain that movement and then get the shoulder strong again. And if patients weren't going to be compliant with physiotherapy, I wouldn't do surgery.
Yeah, it's really interesting hearing you talk through all those three, because obviously as a physio I've seen patients throughout those 3 stages, and I know that we were talking about it earlier, that in private practice sometimes we see patients a bit earlier, so actually the ability as physios to get in there and try and prevent that stiffness phase, and therefore the results of the how long they end up having it for actually can be less than 2 years if, as you say, you can get in there really quite quickly, and you can get the mechanics of the shoulder working. You can really reduce the pain using hands-on techniques and exercises, and as I say, specifically working on that biomechanics, that can be really helpful. But I've also seen patients who've come to me having had steroid injections, and again, that can be so helpful again to reduce the pain and get the movement back, and then even in that last stage as well. So I think what's interesting is that people sometimes, and I'm sure you can vouch for this, is that people want a quick fix, and physio isn't a quick fix. But unfortunately, in this condition, you are going to need to do some physio at some point along the line. So irrespective of the intervention, it's unfortunately not just a quick fix.
I totally agree. I think that there is a role for physiotherapy. In some cases, if the patient's in a very painful inflammatory phase,
Mm,
if the physio focus is mostly repetitive exercise, that
mm,
can flare up
yeah.
that painful phase. And I think that if the patient gets significantly stiff, then the
Mm,
amount of adaptive movement they've got to do is
mm,
going to be, difficult for
yeah.
physio to totally address. But even if physio didn't work pre-surgery, for instance,
Mm.
you're not getting away from physio if you have an operation.
Yeah, yeah, absolutely.
So, we do work closely with physiotherapists,
Yeah.
and as surgeons, we are a bit biased because there will be a lot of frozen shoulder that physios have sorted out in the
Mm,
community,
mm, mm,
and we only get to see the ones
mm,
where the physios have sent to us because they're not progressing.
mm, mm,
So, as a surgeon, it's easy to then think, oh, maybe there's no role for physio preoperatively in
mm,
in
mm,
in
mm,
frozen shoulder, but I don't think that's correct. I think
mm,
that
mm,
especially if they're caught early,
mm,
then physio is very effective.
mm,
Obviously,
mm,
if the stiffness progresses to a
mm,
point where the patient can't be functional, then they're going to struggle.
mm, mm,
And I think the same thing with a steroid injection. I think the steroid injection patients that I have who've had their injection earlier on have made a quick response
mm,
and a good
mm,
recovery
mm,
versus the ones who I see where they come to me 6 months to a year on. I think a steroid injection then is going to be less likely. And
mm,
then we have to
mm,
talk about that one group, the diabetics,
mm, mm,
because if you're diabetic and have frozen shoulder, no matter which treatment option, they have a more aggressive, more resistant form of the disease. They're more likely to fail a steroid injection, more likely to have problems with even recovering after surgery. And
mm,
unfortunately for diabetics as well, they're more likely to have bilateral frozen shoulder
mm,
at the
mm,
same time. So have it in
mm,
both shoulders
mm.
at the same time, which is really unfortunate to have two painful
Yeah.
stiff shoulders all in one go.
Mm, hugely restricting. Yeah. And I really appreciate what you said about that physio, and I think this is really important for our viewers to understand, is that if you're doing physio exercises and they're excruciatingly painful, it is not the right way to go about things, because if you're trying to do exercises and they're causing a lot of pain, all that happens is everything goes into spasm, and then you're trying to move contracted muscles, which just isn't going to work. So yeah, I think that's really key. Is if people are watching this and they're thinking, oh, I've had physio and I've been sort of doing loads and loads of, as you say, repetitive, painful exercise. It's just not gonna. It needs to be a little
No,
bit more. I liked your word finesse earlier. It needs to be a little bit more tailored to their to the individual.
yeah,
Mm,
I do think and that is a problem that we see where some patients with frozen shoulder have tried physiotherapy, and it could be because of the stage or it could be because of the technique, but they find that it's made the symptoms worse, it's become
mm,
more painful, and then we try to intervene, usually with just a steroid injection. We
mm,
almost never would use surgery as a first
mm,
line.
mm, mm, mm,
There are a couple instances where surgery as a first line is appropriate, but they're very, very
mm,
finite.
yeah, yeah, absolutely. Um, so I think probably you and I could talk about this topic for a very, very long time. Just to let our viewers know that I will be producing a video about the physio side of things. So I'm not going to cover that now, but I will be producing videos about how you can look after it yourself, the exercises that are good, those that are not, that sort of thing. So please do subscribe and tune in and do watch that. Is there anything that you would like to add, Nick, before we wrap up today?
Well, also that there are resources as well on my website and my
Oh, of
YouTube
course,
channel
yeah.
around frozen shoulder.
Mm,
I've got some videos talking about the surgery itself and the risks. I've got content on my website about steroid injections, etc. So
Brilliant.
if a patient wanted, that to understand what happens to them if they've been referred to me for frozen shoulder, the kind of processes we do,
Mm, mm,
investigations,
mm,
etc.
mm, mm.
The frozen shoulder page on my website is pretty useful.
Yeah, and I'll put in the link underneath this video to your website, because there's very few surgeons that I know who create as much content and try to empower their patients as much as you. It's really, really fantastic, and I know that our viewers will be incredibly grateful for not just your time today, but for all the work that you put in to empower people with the knowledge that they need. So thank you on their behalf, and also on my behalf, because it's been an absolute pleasure talking to you today.
Yeah, no problem. Same. It's been a pleasure. I'm happy to collaborate if you want to cover the topics. And also, if any of your viewers have questions from a surgical point of view that I haven't covered on my YouTube channel, I'm always creating content. I try to do a batch of videos a couple times a year and release content as much as I can. So if they leave comments in the comment section with any questions they want answered that maybe weren't covered, then I can try and cover that in a future video.
Amazing. Thank you. Thank you. Well, thank you very much indeed, Mr. Nick Ferran, who is a shoulder and elbow consultant in London. And as I say, I will leave his contact details in the video below. So that's all from us today. Please do subscribe. Please do check out the playlists on this channel. Until the next time, let me know what you would like me to do a video on next. Thanks, everyone. Bye.